Hello everyone, welcome back to Nephro Chronicles. In today's video, we are going to discuss Fanconi Syndrome. A very important Fanconi Syndrome is a disorder characterized by generalized defect or dysfunctions of proximal convoluted tubules leading to defective reabsorptions of glucose, amino acid, phosphate, bicarbonate, and uric acid. Glucose is absorbed by SGLT2 receptors and can lead to euglycemic glycosuria. And amino acid is absorbed by sodium-dependent amino acid transporters. Defective reabsorptions of phosphate can lead to renal rickets. In renal rickets, sometimes renal function test is normal. It is very important point, frequently tested in exams. And bicarbonate loss can lead to acidosis. So Fanconi syndrome is also called a renal tubular acidosis type 2. And uric acid, we already see the site of defect. The site of defect is generalized the proximal convoluted tubules. This is the structure of nephron. We are seeing पीसीटी के फिजियोलॉजी बहुत इंपॉर्टेंट है। एग्जाम में कई बार इसको पूछा जाता है। तो पीसीटी के फिजियोलॉजी को समझने के लिए पीसीटी के दो सेल को ड्रॉ करना है। दो सेल को ड्रॉ करने के बाद इसमें एक लुमिनल साइड होता है और एक बेसोलेटरल साइड होता है। लुमिनल साइड में तीन सिम्पोर्ट होते हैं और एक एंटीपोर्ट होता है। तीन सिम्पोर्ट कौन कौन से हैं? सोडियम ग्लूकोज सिम्पोर्ट जिसको SgLT2 बोलते हैं, सोडियम फॉस्फेट सिम्पोर्ट जिसको SpLT2 बोलते हैं, एंड सोडियम एमाइनो एसिड सिम्पोर्ट। एंड एक एंटीपोर्ट होता है। एंटीपोर्ट जो होता है वो है सोडियम आयन हाइड्रोजन आयन एंटीपोर्ट। बेसोलेटरल मेम्ब्रेन में केवल एक ट्रांसपोर्टर पाया जाता है, वो रहता है सोडियम पोटेशियम आयन ATPase। सेल के बीच में अपने को पेसिव पैरासेल्युलर ट्रांसपोर्ट डिनोट करना है, जिसमें पेसिव रीअब्जॉर्प्शन ऑफ वाटर, सोडियम आयन, कैल्शियम आयन, पोटेशियम आयन एंड मैग्नीशियम आयन का एब्जॉर्प्शन होता है। सारे इलेक्ट्रोलाइट जो रहते हैं मैक्सिमम पीसीटी से रीएब्जॉर्ब होते हैं, लेकिन केवल एक मैग्नीशियम आयन है वो थायल से रीएब्जॉर्प्शन होता है। ये इंपॉर्टेंट कॉन्सेप्ट है। इतना समझने के बाद अब हम जाते हैं फॉनकोनी सिंड्रोम के क्लासिकल फाइंडिंग पर। No need to remember by mnemonics. It is very easy. After learn these physiological functions of PCT, so due to loss of glucose can lead to glycosuria without hyperglycemia. With hyperglycemia is diabetes, but without hyperglycemia is either Fanconi syndrome or SGLT2 inhibitor drug uses like canagliflozin, dapagliflozin. To loss of amino aciduria, phosphaturia, proximal renal tubular acidosis can lead to normal anion gap metabolic acidosis, hypokalemia due to secondary RAS activations, hypophosphatemia can lead to renal pathophysiology of Fanconi syndrome, impaired functions of SGLT2 receptors, glucose is continuously lost in urine, can lead to glycosuria with normal blood glucose strongly suggests of Fanconi syndrome because amino acids are lost due to impaired functions of sodium and amino acid cotransporters. Amino acid is continuously lost in urine, phosphate is continuously lost in urine and lead to renal rickets. It is very important point. Renal rickets is due to loss of phosphate, not due to loss of calcium. Very important exam questions is causes of Fanconi syndrome. Causes of Fanconi syndrome is either congenital or acquired. Congenital cause, Wilson disease is most common cause in adolescents. Multiple myeloma like myeloproliferative disorder is can most common cause in case of elderly patient. And drugs or toxicity. Drugs or toxicity is most common cause in case of adult. All the causes, cystinosis is the most important and frequently tested question from this topic. Acquired causes, multiple myeloma, light chain can injure proximal convoluted cells and produce Fanconi syndrome. Heavy metal poisoning like lead, cadmium can lead to damage of proximal convoluted tubule cells and lead to Fanconi syndrome. Drugs like tenofovir, ifosfamide, outdated tetracycline. It is very most common important cause in case of Fanconi syndrome in adults. All these, tenofovir is the most important, which is the antiviral drug. In case of children, failure to thrive, meaning poor weight gains and poor growth. Growth retardation, rickets. Rickets is due to chronic phosphate wasting. These children may have skeletal deformity and delayed growth. In adults, adult typically develops osteomalacia, bone pain, muscle weakness, polyuria, and dehydration. This Now let's move to the laboratory findings, which are extremely important for MCQ-based examination. First, let's discuss the urine findings in case of Fanconi syndrome. Urine examinations show typically glycosuria, aminoaciduria, phosphaturia, bicarbonaturia, and increased uric acid level in urine. In that glycosuria occur despite normal blood glucose level. So whenever you see glucose in urine with normal serum glucose, Fanconi syndrome should immediately come to your mind. This finding reflect defective glucose reabsorption by proximal convoluted tubules rather than diabetes mellitus. Now let's look the blood investigation picture shows low level of phosphate, hypokalemia, and low level of bicarbonate with normal blood glucose. This is very important point. Let's understand the difference between Fanconi syndrome and Fanconi anemia. Fanconi In Fanconi syndrome, glycosuria, aminoaciduria, type 2 RTA, hypophosphatemia rickets, and also hypokalemia. Fanconi anemia, it is a DNA repair defect. Bone marrow failure, pancytopenia, means anemia, leukopenia, and thrombocytopenia, congenital anomaly, and also increase the risk of AML and MDS. Let's move to important associations of Fanconi syndrome. Fanconi syndrome is associated with type 2 RTA, hypophosphatemic rickets or osteomalacia in case of adult, hypophosphatemic rickets in case of children, growth retardations, and polyuria. Important key points include most common inherited cause is cystinosis. It is autosomal recessive disorder. Site of defect is proximal convoluted tubules. Type of RTA is type 2 RTA. Drug causing Fanconi syndromes are tenofovir and ifosfamide. Glycosuria with normal blood glucose, always think Fanconi syndrome. Glycosuria with normal blood glucose, always think about Fanconi syndrome after ruling out the use of SGLT2 inhibitor drugs like canagliflozin and dapagliflozin. Child with rickets and aminoaciduria, always think about Fanconi syndromes. One importance, like Fanconi syndrome is generalized defect of PCT causing loss of glucose, amino acid, phosphate, and bicarbonate leading to type 2 RTA. Type 2 RTA is the normal anion gap metabolic acidosis. In children, hypophosphatemic associated rickets is very important clue for the Fanconi syndrome. Thank you.